Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
Hello, everyone. It's my absolute pleasure to introduce you to this week's guest, Dr. Sandeep Kapoor. Dr. Kapoor is a specialist in internal and geriatric medicine, and he is deeply committed to the conditions associated with aging and longevity. Dr. Kapoor is also keenly interested in the prevention and treatment of Alzheimer's disease and dementia, and is sought out for his innovative vision that provides a better treatment option in the fight against cognitive decline. By utilizing a precision medicine approach, he investigates the root cause of chronic illness, enhancing the framework for his crafted treatment. Precision medicine is based on genomics. Dr. Kapoor is an expert and published author in the field of genomics and utilizes it to deepen his understanding of what makes a patient unique, leading to better outcomes. I met Dr. Kapoor several months ago and was absolutely fascinated by his global and comprehensive approach in treating patients with neurocognitive disorders, and specifically Alzheimer's disease. Please enjoy my conversation with Dr. Sandeep Kapoor. Well, good morning, everyone. I'm here with a new friend and colleague, Dr. Sandeep Kapoor, and Dr. Kapoor and I met and crossed paths a couple months ago now, I guess it is, or a month or so ago at the American Academy of Ozone Therapy meeting, which was, I thought, a fantastic meeting, not only from everything that I learned, but the new friends and colleagues that I got to know and meet, such as you. And so I think today's discussion is going to be really a fantastic discussion. I'm very interested in Alzheimer's disease. I've talked about my personal story with losing my mother to Alzheimer's disease, and you and I had talked about that before. And so not only do I admire the work that you're doing, I also have kind of a vested interest in it for sure. And it's a problem that I don't think anybody can escape from. Whether if you have friends and family, you're going to get into the arena where you have to worry about neurocognitive issues. So, well, thanks for coming on. I know you're super busy, and you want to tell the audience just a little bit about how you practice and what led you to be here today.
Hi, well, thank you for having me. It was great to meet you also at the conference. This is how we actually, with like-minded practitioners, is how we grow this field, thinking outside the box. I'm a geriatrician, so I started off life 20 plus years ago, really trying to solve the complexities of aging. Way back when it wasn't necessarily popular. It was the idea of chronic illness in a traditional model, really from internal medicine to geriatrics. So this is really just an evolution for me in my own practice, where I practice as a solo practitioner and have been faced with many chronic illnesses. But as people age, the risks for Alzheimer's and cognitive decline increase steadily, and I have been faced with treating people all through my career, and with the few medications that we have on the market, and some of them had some success in slowing their decline, but inevitably they all declined, and that was sort of heartbreaking in a sense to watch that. I too have a personal experience. My grandmother had Alzheimer's disease when I was a teenager. And so this was but we didn't even call it that. We just called it, sort of crazy old lady stuff, and that's really frightening, but that sort of led me to geriatrics in a way, and the study of the brain. I think that in my education and understanding, and when going back to doing something different, is what around 2017, when I really started to study and went to a conference where Dr. Dale Brederson was speaking about his reversal program, or his research as a neurologist into the area of actually doing something different than just looking at medications, but really having great outcomes. And that research has now grown into proven protocols for looking at Alzheimer's disease from a really holistic place, a integrative space, a functional medicine space, lifestyle medicine, and figuring out what the cause is really of why that person's having trouble with their memory, so that we can then sort out a treatment for it. And we've had, Dr. Brederson's had a lot of success, and he's grown a big program. And I'm having a lot of success too in getting down to a different approach to Alzheimer's disease and cognitive decline. And it's fascinating. And it's fascinating, because it's getting people better and reversing the trajectory and of many of my patients, and giving them the life back. And that is a passion that I have, and I'm going to continue to dedicate the rest of my career to figuring this out, to continue to figuring this out.
What was the impetus in your pathway as far as going from more of the traditional allopathic approach into integrating functional medicine? Was it that you got frustrated with not seeing any results, or was there some kind of tipping point that pushed you into the direction of where you're at today as far as treatment?
I think it's a combination of those factors. I mean, I was not seeing, I was constantly seeing people decline like they're going down these slides, and sitting by watching someone go from mild impairment to full-on dementia, in some cases, in under a couple of years. More so in women patients that I've had, decline is super accelerated, and I'm like, it was tragic, and seeing families destroyed, and spouses, families, children destroyed. So it was that, and plus when I got interested in after that lecture, actually, really it spurred on my whole involvement in functional medicine at the Institute for Functional Medicine. And so now I'm adept and trained at how to approach every case with a lens that is wider and precise in so many ways. So that's really where it came from, just really the idea that, we weren't getting people better through traditional methods.
Well, and you make a point about the families as well, because this is one disease or one pathology that affects more than just the patient, and it can be incredibly burdensome as far as from a financial standpoint, the cost of memory care, not to mention, put all the economic things aside, but the emotional disruption of the families and caretakers, and it can take a tremendous toll on not only the person who suffers from the disease, but also the people who are caretaking for that person as well. So it's got a pretty wide web of how it affects people out there. Your paper, which you presented a lot of this data at the Ozone conference, which I thought was really great, because everybody talks about, the FDA approves these drugs. They just approved one a few weeks ago, and they measure it in, it slows down the decline. Doesn't do anything to increase their scores on a cognitive test or anything like that. But yet in this paper, you were able to show that you were able to not only slow the decline, but reverse it and improve substantively. And in many of the cases, I think it was about half that you were able to actually do something more than all of these, billions of dollars of drugs that haven't done anything as far as slowing something versus reversing something. I think that's a big deal.
Yes, I think that was the impetus to really get some of this work in the publication, was to start to understand that we are getting people better, and that is not the norm. Of to see that there is a, over 50%, improvement in these patients that we just looked at through 3 different sites, 3 different doctors. And, we're all doing it sort of siloed. And so now the idea is to get this to a level where we're actually spreading the word and finding ways to engage and understand that there is another option. And, I'm absolutely not opposed to medications that are cutting edge, or that have, the medicines that are recently approved, unfortunately are working on a hypothesis that is very, is 20 to 30 years old, just looking at amyloid or that protein. And they also come with a lot of side effects and contraindications, such as brain bleeding. And so ultimately doing no harm is first the case. But, we want to do some good with our medications. So,
yeah, I think you make a great point there, because you talked about in the article about that Alzheimer's disease is not a monogenic disease, meaning that, for the audience that doesn't understand the $20 medical terms, but monogenic just means that there's one thing that's causing it, one thing that is creating this disease. And I think, you look at a lot of the drug development, and they're always chasing one pathway, or they're chasing beta amyloid, or they're chasing tau proteins. They're not really looking at it as a complex situation with all of these different cofactors that are going into it. And I don't think they'll ever, this is my opinion, and you may totally disagree with this, but been a lot of money spent in that direction with a lot of failure and very little benefit coming out of it. It seems to me that if they reapportioned, and they won't do this because it's not patentable, but if they reapportioned their efforts and their the grants and everything to maybe what you're doing here, it could have a dramatically better effect.
Yeah, I think that's the what Dr. Brederson study, with his 12 or 20 patients showed, an 84% increase in cognition, directly compared it to the medication that was released in their data. And that was a proof of concept study. So it is a small army that's coming. We're a small army that's really coming, and we're not flush with a lot of pharma dollars, because we're not producing a one drug system.
Right.
And the system that we're approaching is a network imbalance, essentially. The network, that there's a multi-system imbalance. So when we look at disease in general, we really want to look at the exquisite balance that needs to be created in the system. I think that and going after one balance, or focusing on one neurotransmitter and giving that person back a neurotransmitter for memory or brain memory, it's very naive to think that the body and the systems that we deal with are so complex. And we are just, the idea of looking at it from a multiple network kind of situation is to look at how to restore balance, not to have too much of one thing and not enough of another. And that's really what, striking that balance is really where we see success in the treatment in these cases.
So in 2017, when you started looking at this from a more functional perspective, was that before you were able to get the genomics testing, or was that at about the same time? Because to me, it seems like with this genomics testing, it's a really powerful thing, because we know that, you metabolize substance A vastly different than I metabolize substance A. So to have the power of this type of genomic testing that you're using, I just think amplifies everything that you do, because now you can kind of focus on those particular things that may be the most glaring that you get from the genomics report.
In 2017, I didn't know anything about genomics. In fact, they scared me, genetics. I'm like, there's very smart people that are doing all sorts of you know, family trees and all this kind of brilliant stuff. But when what I was introduced to genomics through Intellect's DNA, it was absolutely, because I went into it looking for cognition genomics. I knew it was around, and I picked that based on just thinking, well, they have a cognition panel, or they can tell me more about people's brains and memory. And then I discovered that there was so much more. If you look, you've got to look at the heart, you've got to look at the kidneys, you've got to look at metabolism and diabetes and all of these factors that are built in people. This is their roadmap that they have. This is what makes them unique. This is what makes them different beyond what color eyes they have or what color skin they have. There are so many unique there are unique issues related to their own individual biochemistry of how they assimilate or how they work with the nutrients or how they work with substances within their body are unique to each and every individual. Okay. And that was what we can harness. And we can harness that so that now we get to a point where your blueprint is different than somebody else's. So when you face a disease state like cognition and cognitive decline, we can really identify much more precisely the root cause. And when we can do the root cause, we can also have treatments for it. So everything that is the items that I study in genomics and the tool that I use is something that we can do something about. So it's a action plan, versus it being like, well, geez, you have this and there's not, oh boy, you found out you've got an ApoE4, which is the most common gene that most people have heard about, right. That is involved in increasing your lifetime risk of developing Alzheimer's disease. But there are so many more. Well, first of all, the ApoE4 gene interacts with 1,700 other genes to turn off or on different processes in the body. So if you looked at just one gene and you didn't look at the others, this becomes, you're now just looking at one idea, and you need to be able to look at the hundreds of other genes that are also affected that can involve cognition.
So in your paper, you had one patient that was a ApoE4/4, I believe, and then the others were 4/3s. And
yeah, I believe all of them were. There was one patient that was not my patient, but it was another. It was I believe a 4/4, but all of them were 3. At least had one copy
of the 4.
Of the 4.
Okay, yeah. And I think that people have been aware, for a while now about the ApoE4 versus APO3 versus APO2. I think that's pretty well understood. I didn't know that until reading your paper that ApoE4 reacted with 1,700 different other genes. And that goes back to illustrate what we were talking about, the complexity of this. It's like, this is not just put plug A into hole A and plug B into hole B. It's far more complex than that. And so I'm going, in addition to, knowing what your ApoE genetic makeup is, what's some of the other SNPs that you really like to focus on? I thought the one with the glutathione enzymes was interesting. Is there something else that sticks out? Like if you had your top 4 things that you wanted to look at?
One of the main ones is methylation. I mean, methylation is a process in the body that is assimilating very vital nutrients, the B vitamins essentially, right. Into the body and brain and then into the system. And I think that is the most fascinating, because there are not just one gene, there are at least 20 to 25 genes that are coding for different proteins that makes that system work well. So when there is a dysfunction in one of those pathways, or there's an interruption, it's kind of like the chutes and ladder issue. You can't get to step B or step C without having the enzyme that's converting this particular process. So it kind of interrupts that. So what does it end up interrupting? It ends up interrupting the production of neurotransmitters for the brain. It interrupts a lot of different protein synthesis, DNA synthesis. So that was the most fascinating. And really, for a patient like the one that I presented, was that in combination, so if you have the methylation gene, the MTHFR gene, with a inflammation gene called interleukin-6, which shows that you have a higher levels of brain inflammation. So the combination actually increases your risk of vascular disease almost fourfold, vascular dementia.
Right.
So that's one of the most striking ones I'm also looking at, and those are also patients that are ApoE33. They have seemingly average risk or normal risk as you age, and then people say, well, I don't have that gene, so therefore I have a free pass, for Alzheimer's or for or for cognition or dementia. But actually, if you look deeper, you can see other issues that are uncovered, like the MTHFR interleukin-6 combination, that would increase your risk fourfold. So therefore, I'm going to point my fingers at everything I can do in a vascular basis to decrease that. So the one way to do it is to mitigate the effect or help that pathway. So I'm going to correct the methylation pathway by giving a certain type of B vitamin, which is a methylated folic acid, and replace the B12 appropriately, B6, but all those, I'm going to affix that one. So I'm going to mitigate the risk of having that MTHFR variant. And then I'm also going to go hard after interleukin-6, which is, so therefore I am minimizing and have direct interventions for interleukin-6. And therefore I am going to hopefully then kind of cross out that risk or diminish the risk of you developing vascular dementia.
Do you think that there might be a component of vascular in almost every neurocognitive disease?
I found that I give a talk about kind of like looking at how many different types of dementia, Alzheimer's being, responsible for 50, 60, 75%, and then there's a 25, 30% risk of vascular dementia. But it is, in my opinion, it's starting to look very mixed, right? You're going to have both a risk of Alzheimer's, and you're also going to have vascular. I think blood flow in general is diminished in the States. If you have, for example, peripheral vascular disease, to me equals brain disease. I mean, so you're not getting, if you're not getting flow to your extremities, you're also not getting flow to certain parts of the brain that are generally not given enough blood flow to begin with. And so they can be, over time, can have consequences in there. So absolutely, I think blood flow is what I'm seeing over time. Cardiovascular disease and diabetes and the metabolism diseases of arteries are really a hallmark of understanding what happens to the aging brain.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. I'm excited to announce that we have a new sponsor for the show. Dr. Ed Glazer's Relax, Release, Relief Technique and Training is now a sponsor of the Pod of Inquiry. I call this technique the Triple R technique, and it's truly amazing. He has actually performed it on me. By asking your patient to point where it hurts and have them tell you what motion hurts them, you will know exactly how to position them. They will then lightly push against your very focused light pressure, so minimal pressure that they can barely feel anything. A few seconds later, you will feel a softening of their tissues under your fingers as the patient's skin separates from the deep fascia and suddenly slides. This is the release part of the technique called relax, release, relief. It's a deep relaxation technique that reduces or eliminates almost all pain. 10 minutes after the release, most musculoskeletal pain is gone. The range of motion increases dramatically and permanently for most people. Muscle spasms, including trigger points, are gone. Duration of relief or recurrence is dependent upon the underlying cause of pain, which in most cases has already healed. It does all this by resetting the pain threshold. It's as easy as flipping a switch, and the results are astonishing. I know, I've had the experience myself. What I'm saying is you learn this technique and you'll be able to relieve a lot of musculoskeletal pain from surgeries, trauma, implants, and other diagnoses, including fibromyalgia and CRPS. Dr. Edward Glaser is the inventor of the Soul Support Mass Posture Orthotic and is teaching the lower and upper body in 2 weekend courses. I personally have experienced this treatment, as I've said, from Dr. Glaser, and it does relieve pain, and the technique is painless. Space is limited for these courses to 14 students in each class. Just go to rrrtv.net/course or tap the QR code on the screen to register. You'll want to really do this because it will empower you and give you a technique that really helps people and really will differentiate your practice from almost any other practice. Dr. Glaser's teaching 2 courses. Course 1 is feet to low back, and Course 2 is upper body. Now, the first course, feet to low back, is being offered on October 4th and 5th and November 11th and 12th. And the upper body course is being offered on October 28th and 29th and November 18th and 19th. So go to rrrtv.net/course and get signed up for these today. And I don't think there's any argument that as we get older, we decrease our abilities to manufacture nitric oxide, which you can empirically, translate that into less than an ideal perfusion, regardless of where it is in the body. So I think that's real interesting. One of the things I picked up from the article is that it said that ApoE4 individuals have a compromised mitochondrial function. I didn't know that. I'd love for you to tell me a little bit about that, but then also let's tie that into diabetes if we can, because there appears to be a super high or increased odds ratio of neurocognitive diseases as well as cardiovascular diseases in patients with type 2 diabetes.
Yeah, so I think that, yes, when you look at mitochondria are those little energy batteries of the cells, and they are in every cell, and in neurons are associated with that. So those batteries, those mitochondria with patients that have ApoE4 have impairments in the little membranes that surround those mitochondria, meaning they get gunked up with amyloid, with other tissue that is not allowing the influx of the vitamins and the nourishment that the mitochondria need. So the whole focus and goal of really treating an ApoE4 individual is to really strengthen their mitochondria. So to use mechanisms to kind of ungunk, if you will, the pores around those little batteries called mitochondria. So if we can feed that better, we can do a better feeding system, we're going to see the energy of the brain cells function better. That's the approach with mitochondria.
I recall something, and I think it was from Dale Bredesen's book, but it may not be, but there's a very high association between increased insulin and formation of either, if it's not beta amyloid, it's tau proteins, but I think it's beta amyloid that in a situation where you have an excess of insulin, it overloads one of the enzymes. I think it's like insulin degrading factor that also works on beta amyloid. Am I recalling that? It's been a long time.
Yeah, so it's certainly the factor of the sugar. I mean, the brain needs fuel, needs fuel. They need sugar. It needs but there needs the right kind of sugar is how I look at it. And I say, well, if you have and you have insulin as your delivery system, and when there is excessive types of the poorer types of sugar that are floating around the bloodstream, including your brain, that creates a resistance. So your brain can be insulin resistant, meaning not accepting the insulin, therefore not accepting or not being able to accept the fuel, the fuel of sugar, and therefore there's an impairment in glucose metabolism in the brain, and it yields inflammation. So it will lead to the buildup of amyloid and possibly tau, but it's amyloid itself, because amyloid is thought to be a protein response to an inflammatory state, an inflammation state. It is a protective mechanism that the brain invokes when there is inflammation that is present. So the Coca-Cola that's being mainlined into the system, or the the wrong kind of sugar, fructose corn syrup, etc., is going to have a problem being assimilated into the brain.
So let me interrupt you there, because I want to ask you a question, and just to help clarify this process that I'm trying to put together in my mind to understand it a little bit better. So you're saying that the ApoE4 folks have impaired mitochondrial function. Is that something to do with maybe the GLUT4 transporter, that the insulin's there, but they have insulin resistance, so they can't really get that glucose through the membrane?
Yes, that's okay. Part of the process of having an insulin resistant brain and nerve cells. So they're not able to assimilate the fuel as well. Okay.
And then it builds up outside, overloads this other insulin degrading enzyme, right, and then it can't chew up the amyloid like it's supposed to. But I think you made another great point there, and that is that amyloid is a protective mechanism. And what have a lot of the studies, or excuse me, the drug trials focused at? To get rid of the amyloid, right?
Yes.
And so are they barking up the wrong tree?
Well, they're not going far enough upstream, right? Okay. They're looking at end product, which is one amyloid. So the production of amyloid, but they're not looking as to why it is occurring, right? So we can understand that when we look at the variant in ApoE4, it is a cleavage problem when you have, when you are trying to break down beta amyloid, and you have a ApoE4, it is not cleaving it or not breaking it down to as efficiently as someone who is an ApoE3 versus even an ApoE2, which is a protective genetic variant that actually lowers your risk of Alzheimer's almost by 40%. If you have that ApoE protective gene, because it is coding for a protein that is literally sweeping through the brain and cleaning up amyloid barely when it starts. So you have, and also the cleavage, it goes to a very effective form of amyloid that is not harmful and is degraded. So yes, it is about production and degradation, but if you just go and see the brain that is riddled with amyloid, or you're trying to remove it, and then you can see on a scan perhaps that there's been some removal, or there's been a less of it. You do an amyloid scan afterwards, after treatment, and you say, wow, that's a success because it's decreased the amyloid. But the problem is the patient isn't better.
Right.
The patient can't remember anything more. They're just the same, or they if declining at the same rate or the same. So what is the treatment efficacy then when you're looking at, so they're way downstream, they're not looking at the source of the problem when they go for the amyloid theory. And we now know that the amyloid theory is old, meaning that it's not the only factor. I mean, there's tau involved, right? Tau proteins. There's brain inflammation. There's that metabolism issue. These have not been addressed through any known clinical trial that I'm aware of in terms of trying to target that. So what it comes down to is that as geriatricians or internists or physicians in general who are treating older people, we need to look at their sugar. We need to, it's not a tough concept to understand what insulin resistance is to a physician and understand why that's important. When I first started out in geriatrics, we were and talking about diabetes in an older patient, we were saying, well, we will have a permissible high sugar because we don't want because we were giving them medications and we don't want them to end up on the floor passing out from low sugar. So that's the whole, giving them insulin or giving them, and that's even before there were like, long acting insulins and things that were helpful. So we gave this sort of permissible in my training. That's how I was trained. Like, well, allow them to have their sugar and let them eat ice cream, let them eat this, and allow them. It's a nice thing to have. You're older now, have whatever you want, and no worries about your sugar.
Right.
That whole concept has changed for me. I'm so hyper vigilant on people's diets now and nutrition, and I don't let them eat sugar, and I have to wean them off. But they do.
Well, sugar's a super addictive. It's one of the most addictive chemicals known to man, in my opinion. I mean, there's some studies that show if you put sugar water and cocaine water in the rat cage, the rats never touch the cocaine water. It's kind of interesting, how
exactly.
how powerfully addicting sugar really is. So it would seem that with this type of a protocol, which I think is fantastic, that if it was intervened in patients with early cognitive, or let's call it MCI, mild cognitive impairment, I would think the buy-in from those patients would be easier because they could, if they're really interested in getting themselves well, they have a more of a cognitive basis to understand what you're doing at this point in time versus someone, unfortunately, who's farther down the line on the neurocognitive scale. Is that assumption correct? I mean, it's hard to get somebody that has difficulty communicating to understand all of the things that you want to do.
And that's why it's so important. I mean, the idea of meeting people where they're at is an important concept. Yes, absolutely. Mild cognitive impairment, we're going to see a lot of inroads into understanding motivation and understanding and having that patient be able to understand what they're doing. But it requires, even with that, it requires this team approach, like the spouse, the caregiver, the children, whoever we can find the champions, we need to engage the champions.
Right.
To be able to, so even with a patient who has I see patients and I put them on this protocol who have dementia, who are out of 30 on the scale of all the scales that we do, 30 out of 30 on the Montreal cognitive scale. Patients that are 17, 18 I've treated, and those patients are not able to really function to a point where they understand, and they are not able to drive, they're not able to do that. Those patients still respond when you have that teamwork in place. When, I have the patient has a daughter-in-law with him, and the spouse, the son-in-law, whoever wants to come to the team. It takes a village. It does really take a community to be able to get these people better. Right. And that's why we also have health coaches in our own practice who are also designed to follow up and make sure people have questions, because it's not easy to necessarily just change sort of everything that you do about eating or lifestyle and exercise and doing. There's a multitude of things to do. The reason to have a protocol is to be able to understand that we will help you through each part of the protocol and guide you, but we're not there, so to say, in your house. So that's where the extenders and the people to be able to do it as a team. It's really empowering the family and the unit. It's not able to be done alone. Even for someone with mild impairment, it is imperative that they have somebody. It doesn't always have to be a spouse but sometimes we'll do both together. We'll sort of look at them together. Because the key is also prevention. I mean, I think
Right.
that there is something called subjective decline also, where people are worried about brain fog, and they may not have objective findings on some of these, scans that we do, or even just some of the cognitive testing that we do. And it can be very frightening for people when they're doing some of these tests. I mean, I test all of my patients and mostly at 55 or 50 and over. I probably should go, I'm going to go lower on that, because there's different tests we can do for younger people. But the idea is that you want to be able to pick it up and not have fear about it, right? Because there are certain ways that you have to approach it. But if you do have the knowledge is power for anything, then you can really press hard on the preventative aspects.
Right. And I think that, when you lay out a comprehensive plan like this, it's a lifestyle change, not just a medicine. And there are some folks that just want you to pull out your prescription pad and write that one medicine for them, because they don't really want to have to do all of the work, and they don't want to give up their ice cream at night and make these lifestyle changes. So you have to have some kind of a selection criteria, I would think, to make sure that they're going to try to implement these efforts. Is that fact?
Definitely, yeah, definitely have a qualification factor. When I have a program that people come in and we want to see how motivated they are to be able to do it. But I also have everyday patients that I'm screening and seeing that there are the inroads. So sometimes we have to take baby steps. It's in terms of saying, hey, we can do one thing. We can take out your sodas, for example, like stop drinking soda. And so we do walk along a path that is unique. I mean, protocols are meant to be implemented as instructed, but invariably that's where the coaching comes in. You got to pivot and do things differently, so that people say, well, people changing their lifestyle is difficult, or it's something that needs, but when they see that there's a pathway to independence, there's a pathway to getting your driver's license back if you have lost it because of some cognitive impairment, you have a motivation there that is unsaid. And a lot of these people that come to me have been told by a neurologist or by somebody who has done an evaluation that there's nothing they can do about it. So they've already kind of been given that one prescription. They've been given that, and they've been taking it, or they've had side effects from it, and they have noticed nothing from it. They've noticed no improvement. Maybe they're not getting worse, or maybe they are getting worse, and they're just continuing on. So there is a sense lately of like, well, what else am I going to do besides go home and start to prepare for decline, which is what they're told frequently. Get your affairs in order, get your figure out your will and your trust, because this is going to be something that you're going to not be able to do in a couple of years or in a couple of months, or, give up your driving. And all of these things are just told to them from the medical community. And that is, so when they are coming to me at that point, they've already probably been through the realm of being told that there's nothing they can do.
I think that's an important thing that we convey today, is that regardless of whether you're an APOE4/4 or 3/3 or whatever, you can still develop the pathology, and you can still reverse the pathology with these comprehensive lifestyle and supplement changes that you do. There's another factor here that goes against us as far as this type of approach versus a one drug, one disease approach. And that is that it not only takes a tremendous buy-in from the patient to say, okay, I want to do all of these things, which is not easy. And then it also takes a buy-in from the physician that says, this is a lot of work, because I have to really analyze this patient from a metabolic standpoint, from your internal medicine, everything that you would look at them from, hormonal, all of these considerations. And then you have to take this incredible genomic testing that you have, and then you have to look at these different SNPs that they may have and decide which ones do I want to prioritize? This takes time, and it doesn't fit into the system where somebody is seeing 70 patients in a day. It just doesn't work.
It's a big conundrum, and it's a conundrum because there aren't centers doing this, and there isn't enough of people doing this, doctors doing it, nurse practitioners doing it. I mean, so that it becomes a tedious task. I mean, currently in my own practice, even I'm pretty much the only one that has the genomic background. I've hired a new physician, a naturopathic doctor, but who is going to be onboarded and trained in there. But we need to have broader training. We need to have ability to have this reimbursed by insurance, by Medicare, and seeing the value of what this brings in terms of saving money and saving cost and saving lives. That's one thing we like to do. But when it comes to an economic standpoint, there isn't currently a reimbursable pattern for this, and that's what we hope to change with doing research and doing the projects that Dr. Bredeson's involved with, is really to be able to bring it to mainstream, to say that you can do this, and it doesn't always have to be a physician who is tasked with the whole idea. That's the idea of health coaches and nurses and physical therapists and dentists even. We have some dentist training to be able to pull this together and do these programs.
No, it's great. And I think what will happen is, once there's more research like what you've done in the non-mainstream world, so to speak, then that will maybe spur on funding for, trying to get certain, insurance payers to pay for this. Because in the whole global cost of things, I mean, the amount of money that's being spent in this arena is staggering. And it'd be great if they could reapportion some of that to actually getting people, so they don't need to be paid for memory care. They don't need to have to be warehoused and just basically be put away until they pass away physically, because they already passed away mentally, unfortunately. And that's the truly sad thing about Alzheimer's, is that you die twice. And that's when, it's very, very hard. And I think the first death, the cognitive death is harder for the family than the physical death. And
because they're still physically there, and they may be actually very physically strong. And it is devastating to not have your loved one not recognize you. And it's really heartbreaking. I've seen too much of that and it slips quickly. So we have a task. I mean, even the idea of being able to do something like this in a home and an assisted living, and that's what my goal and passion is, to be able to develop a home where we are having people go for a brain reboot, where they're immersing themselves in that old lifestyle change, and that using all the modalities that we have identified as things that are going to start to get them better, and then be able to send them home with a changed lifestyle so that they can maintain it. Key is that if you can maintain it, you are going to be able to sail through. So it's sort of like pour it on heavy in the beginning, give them the tools that they can use and then they get addicted to that lifestyle. They get addicted to feeling good. They get addicted to being able to feel spry. And, I've had patients who have, realized that if they go to a dinner party, and they've been through the program, or they've been, they go to a dinner party, they have to bring their own food, because no one's going to have the kind of keto flexible diet that is there, and they can mess up their brains really by veering off of it. So sometimes they have to bring their own food, and they're like happy to do it, because it's not about going to a dinner party and just eating. It's about going and socializing and knowing what you're talking about, and remembering who people are, and having a meaningful social interaction.
Well, folks, if you are over 40 and you are not using a supplement to augment nitric oxide production, you should really think that. This molecule is absolutely imperative to health, not to mention its cardioprotection. If you have any question on nitric oxide, I suggest that you go back and listen to the Pod of Inquiry, Season 1, Episode 3, for my conversation with one of the world's experts, Dr. Nathan Bryan. I never miss a day of nitric oxide supplementation. That's how important I believe it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett, all lowercase, at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I'm certain you will be pleased not only for yourself, but all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see every one of those patients will be nitric oxide deficient. When they see this result, they will want you to start them up immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.